Audience today from SCI staff, past and present, some people who have helped us with fundraising, people from Imperial College. There are parts of Imperial College that don't know we exist, and we hope that after today they will learn a little bit about us, and visitors from other places in the UK. I have one special visitor that I'd like you to welcome. That's Narcissus Kabatareni, who was flown in from Uganda. He's actually an SCI staff member, so let's welcome him. The idea of today is really that we present the work of our last year to our board, who then meet in more private surroundings tomorrow morning to discuss what we've done. But we thought as we were going to present to the board, we might as well open it up, and I hope that you will find it interesting. This particular year, we've done it slightly differently. In the past, we've had a series of presentations of what we've done in each country. But there's a certain sameness about that, and the number of countries in which we're working has increased quite significantly. So this year, we have some posters. And dotted around the audience are SCI staff members and program managers. And at the tea break, each one will go and man their poster, or lady their poster, as the case may be, and they hope that you will come round and ask them questions about what they've achieved, what their achievements are, but also what are the constraints and what are the difficulties in working there. By popular demand of my staff, I'm going to just tell you a little bit of the history of SCI, because there are an awful lot of new people who perhaps don't know how we've got to where we are. And where are we? Well, when SCI started, it was just about in the year 2000, and this is a map of all the countries that have national schistosomiasis control programs in the year 2000. As you see, just in case you don't realize, the ones in red do have schistosomiasis control programs, and the one in yellows did not. SCI started in, properly I should say, in 2002, and between 2003 and 2006 we were a single funded organisation, and we had money from the Bill and Melinda Gates Foundation. They were very good to us. They were only just starting in those days. It was a very small organisation. I think there were less than 10 staff when we first went over there. And when we suggested to them that they were giving a lot of money for childhood vaccination and malaria, and pointed out that schistosomiasis was quite a problem in sub-Saharan Africa. In fact, there are 10 times as many people with schistosomiasis as there are with HIV. They were a little bit surprised, and they said, well, what are you going to do about it? So we said, well, we would just treat everybody. We've got the drug, we've done it in Egypt. So they said, how much do you want? And I was a bit quick off the feet then. I said, well, $50 million would be a good start. And so they phoned me up a week later and said they'd had their budget meeting, and unfortunately they couldn't give me $50 million. But they said, as a consolation, could you manage with $34 million? So I reluctantly agreed, and I wondered then where to house the project, and I was very fortunate to bump into Roy at a meeting, and I said, I've got this money from the Gates Foundation, I don't know where to put it.
Easy decision.
So he twisted my arm, and we started off at Imperial College, and that's where we moved from. So over 5 or 6 years, we literally were just working very politically correct, as you can see. 3 Francophone countries, 3 Anglophone countries, 3 East African, 3 West African. But since once that money finished, the Gates Foundation basically said to us that they wouldn't support the work again because they support operational research. And what we wanted to do, obviously, was very much implementation. But they did give us a second tranche of money, which allowed us to work on integration of neglected tropical diseases. And they also gave us another tranche of money to prepare some documentaries for the BBC World Service, which was a very interesting experience. And we worked with an organisation called Rockhopper and produced 8 8 films which went out all over the world. In fact, they also organised for me to be on Hard Talk, which was quite an experience because it's totally unscripted and you have to answer these terrible questions which this 6'4" guy, Stephen Sacker, asked you, and with no warning whatsoever. But it does go out all over the world on BBC World Service. And my next door neighbour was on holiday in Zanzibar and switched the TV on to get the football results and said, oh my God, my next door neighbour, I've got to watch him now. But anyway, it was all good publicity. So the point now is, how on earth did we get to where we are today? And this is where we are today because we have some activities at least in each one of these organisations. As you can see, it's cunningly colour-coded, and the legacy country, the 2 countries, Burkina Faso and Mali, were where we started with SCI, but their treatments were taken over by USAID, and USAID handed them to Family Health International. So we have stepped back from Burkina Faso and Mali, but the programs are continued supported by USAID. The black countries are countries which just started because we got support from DFID, and the increasing support from DFID has allowed us to expand into a number of different countries. The larger ones, Tanzania, Malawi, Uganda, Ethiopia, and Niger, we actually cost share with some of the other donor organizations. And then the light blue ones, we are helping to get started with programs using private donated funds. So Mauritania, Senegal, Zimbabwe, and Madagascar. Just trying to see if there's any I haven't actually touched there. The light blue ones, well, I'm not quite sure what that colour is. Let me just say in the Sudan. In the Sudan, we haven't actually started doing anything yet, but our committee of allocation of privately donated funding has suggested that we respond positively to a request for funding from the Sudan. The other 2 countries, which are so tiny that we can hardly see them, are Burundi and Rwanda, and we've had programs in Burundi and Rwanda for 4 or 5 years, and know that will continue. And there's a very good chance that we'll actually be able to go ahead in Burundi and Rwanda with a program towards elimination. We've been very lucky, SCI has been very lucky. When the Gates funding was coming to an end, there was a great possibility that we would have some very well-trained staff, some very enthusiastic countries wanting to have support, but we wouldn't have enough money to actually buy the drugs and deliver them. And then 3 things happened virtually simultaneously, all, I must say, to our benefit. The first was that the rather lack of transparency of the Gates Foundation had started being triggered, or had started triggering reaction among journalists. And I was in quite an embarrassing position because a journalist from the Financial Times came to see me, and he said, would you like to tell me what you think of the Gates Foundation and their funding policy? Well, they've been very generous with their funding policy, so I didn't want to be too rude about them, but at the same time they were telling me they weren't going to give me any more money. So I was a bit disappointed. Anyway, I managed to balance it a little bit, and I said, well, I am disappointed in them because they've started us off on a very big track, we've expanded, and now they say they want to concentrate on research. And he said, well, what would you do if you got the money? And I said, well, for 50 pence per child per year, we can actually treat 3 or 4 or 5 neglected tropical diseases. And he wrote this great screed about the Gates Foundation and just wrote 1 sentence saying, and Alan Fenwick says for 50 pence he can treat a child once a year for 4 or 5 neglected tropical diseases. Some wildly rich financier read that in the newspaper and phoned me up and said, is this true? And I said, yes. And so he said, well, we think this is good value for money, we'd like to support you. And they came in and supported a program. They said, well, shall we choose Mozambique, Angola, Rwanda or Burundi? And I did say, well, one or two will be slightly more expensive than the others. And so they chose Rwanda and Burundi and funded our program from that. And from there has started Geneva Global and the End Fund, which now is trying to raise well over $100 million to support programs. So that's quite satisfying. The second thing that happened was that USAID and the British government at the same time both decided to increase their funding into neglected tropical diseases. I think it's fair to say that the only NTD that DFID had supported up until that time was Liverpool's LF Support Centre. But in 2008, they decided that they would go into schistointestinal helminths and also increase their donation to APOC. We were very fortunate to win the bid, and it was a significant amount that allowed us to work in 8 countries, and we've just had an increase in funding from DFID, which would allow us to move into Ethiopia and into DRC in a big way. So that's why we've got those big blotches on the map there. But the third thing, which has been incredible, is the donation of praziquantel. Now, as you may know, and if you don't, it's in the quiz, I'm sure, praziquantel is the drug of choice against schistosomiasis. It's relatively inexpensive, and with the Gates Foundation funding, we were actually buying it for 20 cents per child. 2.5 tablets cost 20 cents. But when you've got a target population of 200 million to treat, you need an awful lot of money to buy the praziquantel. And actually, donors are a little bit reluctant to spend money when they know that that drug is going to be used, and people may well quickly get reinfected again. And so the World Health Organization persuaded Merck to donate some praziquantel. So for 10 years, we've had more money than we had praziquantel. But this drug donation program is going to increase from 25 million tablets 3 years ago through this year over 100 million tablets per year, and next year 2016, 250 million tablets a year, which is going to be enough to treat 100 million children. But at 50 cents, we're going to need an awful lot of money if we're going to help the WHO and Merck to actually make sure that those countries which need treatment to actually go to get it. My final slide is just an acknowledgement, because I'm standing up here as the founder of SCI, but in fact, without an awful lot of support from an awful lot of people, we wouldn't be where we are today. And where are we today? We're actually at the situation where the World Health Assembly has passed a resolution saying that they're going to go for elimination of schistosomiasis in the whole of sub-Saharan Africa. I guess Albus might well say we're not quite going to get there by 2020, but when he does speak, I'm sure that he will describe the steps towards elimination and how we might get there. We have had, and we have, a superb set of staff at all levels, all disciplines, including mathematical modelers, biostatisticians, health economists, and program managers who go out to the countries and make sure that as we're working with the Ministries of Health and Ministries of Education, that the work's going well. Our advisory board, we've had 2 advisory boards, Roy, although you've outlived them both. We had 1 advisory board for our Gates Foundation grant, and now we have a new and more diverse advisory board for the work that we're doing now. And we've had fantastic support from the School of Public Health at Imperial College. It's not always been easy, I have to say. We have bureaucratic problems because the bureaucracy and the health and safety issues, which I'm sure all of you have come across, have multiplied in the 10 or 12 years since we've been going. We have a very close relationship with the World Health Organization and couldn't do what we do without the Neglected Tropical Disease Department. And again, funding from the Bill and Melinda Gates Foundation, USAID, DFID, and a special mention to 2 organizations which have evaluated SCI. And one is GiveWell in America, and the other Giving What We Can, which is started in Oxford and now has nodes all over the countries, because their supporters actually a lot of them, give us a monthly donation, which it can be small and it can grow, but when it's all lumped together, we've been able to start the programs, particularly in Ethiopia. We've spent a lot of money getting ready for Ethiopia because the DFID money that was announced 18 months to 2 years ago has taken some time to come through, and we particularly wanted to start things in Ethiopia, which was a country that was one of the last to get interested in neglected tropical diseases, but really wants to go forward. And we've been very lucky, as I say, within the School of Public Health, the department, the Partnership for Child Development, where we have a very close relationship in Ethiopia, and things are really moving there. Legatum and Geneva Global and the End Fund are other supporters, as are some private donors that we totally respect their confidentiality, but we've been very, very grateful for everything that they've done too. We're not going to go into the financial aspects today because I really don't think it's particularly appropriate or even necessarily that interesting. But what we've done for the first time is to break our talks into rather cross-country and cross-cutting issues so that you can see where we're going. We have started slowly, but SCI has now assisted 16 countries to deliver over 120 million treatments in praziquantel, and many more with albendazole and mebendazole against soil-transmitted helminths. We now have committed to probably double that number over the next 4 years, so we've got an awful lot of work to do and an awful lot of extra funding to raise in order to be able to make sure that that generous donation of praziquantel is well used. So I thought that, and I hope you don't mind, 1 or 2 people have heard it before, just a little overview of how we've gone in 2002 from literally 0 to treating that many people in that many countries. And all the program managers that we've got here today, I hope will convince you when you walk around at tea break that they're doing a good job. I'm very proud of them, and I hope you'll join me in thanking them.